The annual Virtual Rainbow brings together LGBTQ+ youth and their families, healthcare providers, community members, and other professionals to learn about and celebrate diversity and inclusion. Thank you for joining, everyone, and welcome. Okay, welcome everyone to our next session. The title of this session is Unmasking the Truth, How the COVID-19 Pandemic is Impacting the LGBTQ+ Community and Creating Healthcare Inequities. I'm very happy to introduce our guest for this session, Dr. Katherine Soule, currently serves as the Assistant Vice Provost of the University of California Cooperative Extension, and she's also the Director of the UC Cooperative Extension and Youth, Families, and Communities Advisor for San Luis Obispo and Santa Barbara counties. Dr. Soule seeks to provide solutions to the challenges that youth, families, and communities face, and she focuses on the creation of innovative and effective interventions, policy-relevant research, and educational trainings. She's joined in this session by student intern Danielle Pacheco, student intern Trent Baldwin, and designer Moon Moua. You can read more about Katherine, Danielle, Trent, and Moon on our website. Thanks so much for joining us today, and please take it away.
Thank you, Paul, and hello, welcome everyone. We are excited to chat with you today about some research that we have recently just finished up that resulted in an educational marketing campaign called Unmasking the Truth. So next slide, please. Thank you. I'm just going to have us all take a second to introduce ourselves. Thank you, Paul, for the nice introduction of me, and I'll turn it over to Trent.
Absolutely. My name's Trent Baldwin. I am a student intern with this project. I attended The Ohio State University, where I majored in community leadership with a minor in youth development. My background is in youth development, specifically working with the 4-H program. This experience has helped me a lot as I want to focus specifically in LGBTQ+ youth development and community work. This really opened up my eyes to a lot more of, youth is just one aspect of the community, all of the health inequities and all of the issues that these communities we worked with faced during COVID. We're all interconnected in a way. So it's exciting to expand my knowledge that way. Pass it on to Danielle.
Hi everyone, my name's Danielle. My pronouns are she, her. I am currently an undergraduate student at Fresno State University, and this project really opened my mind up to the different types of careers that I could pursue. In college, I was bouncing around from a lot of different majors, a lot of different career paths, couldn't figure out what I wanted to do. And then through my time on this project, it helped me learn what I was passionate about, what I care about, and what I'd like to spend my life doing. It led me to then gain confidence in my skills in talking to people, in creating presentations, and really just how to pass on knowledge to others. And that's how I ended up becoming president of Women's Alliance at my university, and really just trying to gain more skills in areas that I would like to develop my advocacy work in and gain experience. And this project really helped me realize that this was something I love to do and to practice those skills.
Thank you, Danielle. Thank you, Trent. And Moon, would you like to introduce yourself?
Yeah, so my name is Moon. I use she, they pronouns, and I'm the designer of this campaign, worked closely with this amazing team. So I'm just really happy to be here.
Great. So here is a quick overview of what we're going to be talking about. So we'll do a quick introduction of ourselves and the project, moving into a little bit about the research of the campaign, and then results, and some time for question and answers. So next slide. Great. So first, I just want to thank the University of California Office of the President for their Research and Grants Program Office. They had funding available for emergency research projects during COVID and selected this project as one of the ones in which to fund. So we really appreciate their support and funding that allowed us to do this work. And also just want to thank several of the folks that were involved in the research component, specifically put a lot of time into helping us develop the questions, as well as think through the results and findings that we were having. So thank you to all the folks that did participate in helping us move this project forward. So the objectives of our campaign were to increase participants' awareness of healthcare inequities for LGBTQ+ individuals during the COVID-19 pandemic, to increase participant ability to support improved quality of healthcare services for LGBTQ individuals, and to increase the likelihood that LGBTQ+ folks will receive care that's affirming and competent during this COVID-19 health crisis. Our hope is that the campaign will raise awareness about the increased vulnerability of LGBTQ folks and the community, as well as to the harmful effects of the COVID-19 pandemic on our community. This educational campaign is the culmination of 6 months of research, development, and partnership. LGBTQ folks are a community that have been largely invisible in discussions surrounding COVID-19, and folks who deserve much more investigation and attention. So through this research, we're looking to improve inclusivity and medical practices, increased access to affirming healthcare, and structural changes such as tracking LGBTQ demographic data and COVID cases, hospitalizations, et cetera, so that improvements in care and support can be made. Next slide, please. Thank you. So by now, we all know that marginalized populations are at higher risk for health complications during the COVID-19 pandemic. And LGBTQ folks are a part of all of those vulnerable communities. In fact, LGBTQ folks are a part of every marginalized and vulnerable group in society, which compounds the negative impacts that they may experience during the COVID-19 pandemic or from an infection. People who are at higher risk for severe illness from a COVID-19 infection, such as those who are admitted to the ICU, have mechanical ventilation, or experience death, include people over the age of 65, people living in nursing homes or long-term care facilities, people with serious heart conditions, people who are immunocompromised, people with severe obesity, and underlying medical conditions. Next slide, please. Thank you. So when we think about these different communities who are at higher risk for severe COVID-19 complications, we do want to recognize the fact that LGBTQ folks are in all of these communities. So for people over the age of 65, we know that the US has an estimated 2.4 million LGBTQ+ seniors, and LGBTQ+ seniors are more likely to be single, not have biological children, disproportionately impacted by poverty, physical and mental health conditions compared to non-LGBTQ+ seniors. And they often rely on chosen family and social networks more than biological relatives, which means that caregivers and support systems may be less accessible to them during the COVID-19 pandemic. When we think about folks who are living in nursing homes and long-term care facilities, we know that our LGBTQ+ seniors living in nursing homes or long-term care facility may not be open about their LGBTQ+ identities, so caregivers may not be aware of these individuals' increased risks. Those who are open about their identities may be experiencing higher rates of mistreatment and abuse, including not receiving proper medical care. They may have increased concerns about the care that they will receive during an emergency health situation such as COVID-19. And COVID-19 and smoking, so there's limited research here, but we know that LGBTQ adults are more likely to smoke than non-LGBTQ adults. And limited research that we do know suggests that smokers are at higher risk for severe complications from COVID-19 than non-smokers. And that could be increased risk of surface, person-to-person spread, as well as severe illness due to lung disease and reduced lung capacity. Next slide, please. And for folks who are immunocompromised, we know that LGBTQ individuals have higher rates of HIV and cancer than non-LGBTQ+ individuals, and that trans folks have 50% higher rates of HIV than the general population. Other chronic medical conditions, LGBTQ folks have higher rates of chronic illness like cardiovascular disease, asthma, and diabetes, and increased risk of exposure. LGBTQ folks are more likely than non-LGBTQ individuals to be working in industry and environments that increase worker exposure to COVID-19, including restaurants, food services, and hospitals. So all of this to say that LGBTQ individuals are a part of all high-risk categories for severe COVID-19 complications. Consequently, healthcare professionals and medical providers need to be prepared to effectively communicate, engage with, and treat LGBTQ individuals during this pandemic. Prior research has found that LGBTQ individuals are less likely to postpone medical care more likely to postpone medical care due to fears of stigmatization, and they are more likely to report poor quality healthcare and abuse in healthcare facilities. Likewise, LGBTQ individuals are less likely to answer questions honestly, which can negatively impact our treatment, care, and access to essential services. Increasing awareness and competency of medical health care providers and professionals and community service organizations is vital during the COVID-19 crisis to support positive health outcomes for LGBTQ individuals. So the University of California Cooperative Extension, in partnership with the Gala Pride and Diversity Center, healthcare providers, and other community service organizations, developed and delivered this educational campaign for healthcare officials, medical providers, public healthcare officials, community-based organizations, and other decision makers in the public. These materials specifically were developed to increase awareness of LGBTQ plus individuals' risk of severe complication from a COVID-19 infection, LGBTQ plus terminology and issues, as well as other educational materials to increase healthcare providers' competency, to affirm LGBTQ plus individuals' identities, and support positive health outcomes in emergency circumstances such as the COVID-19 pandemic. So moving on to campaign research.
I think
are we allowed to ask questions?
We're going to have time at the end for questions and answers.
Thank you.
Right, so Katherine touched on a little bit of this, but in terms of the need for this research, at the beginning of the pandemic, there was a lot of discussion about vulnerable populations and how COVID-19 was affecting them. There was information out there about LGBTQ populations and how COVID-19 was affecting them, but there was a lot of gaps in resources and knowledge. In our initial research, we found that LGBTQ plus folks are likely postponing medical care due to fears of stigmatization. They also report poor quality healthcare and abuse in healthcare facilities, and are less likely to answer questions honestly, which can negatively impact their treatment care and access to essential services. By supporting positive health outcomes for every LGBTQ plus individual, we can increase awareness and competency of healthcare providers, our professionals, and community service organizations to support these positive health outcomes. Next slide. And the purpose for this research was to assess current needs of LGBTQ plus patients and individuals, develop and deliver an educational campaign to increase public healthcare officials, community-based organizations, other decision makers in the public, and increase the chances of LGBTQ plus individuals receiving affirming and competent care during COVID-19. This project was done completely virtually due to the COVID-19 pandemic. We partnered with organizations and professionals across the state of California with 23 partners in total, representing 5 counties: Imperial, San Luis Obispo, Santa Barbara, Monterey, and Marin. Partners were recruited through networks, pre-existing relationships that we already had, or approaching potential partners via phone or email. All major LGBTQ plus serving organizations and centers were contacted. 10 target counties, though, were, we did target 10 specific counties to represent the diversity of California, and we chose healthcare practitioners and community organizations within these counties. Partners participated in focus groups, disseminated a needs assessment survey, and spread educational campaign materials. Thank you. Focus groups were conducted over Zoom due to the COVID-19 pandemic. There were 3 separate focus groups, kind of our 3 different groups that we focused on throughout this project: LGBTQ plus serving organizations, community organizations, and healthcare professionals. Our LGBTQ plus serving organization focus groups consisted of 4 partnered organizations: Argente, which is a youth program run through the Epicenter out of Salinas Valley Pride, the Imperial Valley LGBT Resource Center, and Gala Central Coast. Our community serving organizations focus group consisted of 3 partnered organizations: YWCA Monterey County, Rise Slow, which is a domestic violence and emergency shelter, and Cap Slow, which is a reproductive and sexual health service. 3 practitioners attended our healthcare professionals focus group, with a wide range of medical fields represented, from mental health to gynecology. The discussion in these focus groups was over how the COVID-19 crisis impacted LGBTQ plus individuals, including healthcare access and susceptibility to COVID-19 itself, how community and health practitioners guaranteed affirming care, and what gaps in knowledge and resources exist. We have some examples of the focus group questions that were asked for each of these sessions. Obviously, it was a very wide discussion on multiple topics, but these were our leading questions. Let's give some time to read over those. And we really focused on how have your patients been affected by the COVID-19 crisis, and what gaps in resources or knowledge do you have as our main leading questions. Right. All right. And so our next step was we took all of those focus group discussions, coded them, found main themes, and turned them into a needs assessment survey questions. The survey included demographic questions. Most demographics were self-identified sexual orientation or gender, Likert type questions, and several open-ended questions. There were 3 main groups mirroring our 3 focus groups: our LGBTQ+ community members with 25 total survey questions, our community organizations with 21 survey questions, and our healthcare professionals with 20 survey questions. This was created over Qualtrics, and it was disseminated via UC A&R channels. Also, our 23 partners also helped to spread this needs assessment survey out, and it was sent to California major healthcare organizations and associations to target physicians. Yeah, so I'll pivot to Danielle.
Hi, everyone. So as we've seen so far, our project required that we complete a series of steps in order to keep progressing. So for us, this meant that we constantly had multiple rounds of results. Our first round of results came after we conducted the focus group interviews that Trent discussed. And you can see a main summary of our findings on the screen. So from our community and LGBTQ+ organizations, we see that there are several big problems that LGBTQ+ individuals are facing. Due to COVID-19, many facilities were closed, and this is really hard, especially in areas where there are limited facilities to support the LGBTQ+ population there. We also see how many youth were stuck in non-affirming spaces, whether that was due to quarantine or to schools being closed down. But this can be really traumatic for someone to go through if school is your place where you can go and openly live out your identity and how you are. It's a break from having to go home to a non-affirming space. So that really negatively impacted a lot of LGBTQ+ individuals. And another key problem we noticed was that it is hard for service providers to know if someone is affirming. So when organizations are trying to refer their clients to affirming places, they can't always know what kind of care their client is going to receive. And on the flip side, this also makes it hard for LGBTQ+ individuals to know what to expect at a provider's visit. And this really correlates with the prior research we were discussing that shows LGBTQ+ individuals are likely to postpone medical care due to fears of stigmatization. And this is because a lot of the times when they go to providers, you don't always know the kind of treatment you're going to receive, and that can be really damaging. And then for our healthcare providers, we see a difference in results and really a lack of provider understanding for LGBTQ+ needs. Essentially, we saw that there are good intentions, but that doesn't necessarily translate into affirming care. So we have our LGBTQ+ groups are saying they want affirming care, but that providers don't always know how to do that. And this requires being intentional and making the effort to learn how to be affirming. But one surprising takeaway from this interview, at least for me, was learning that due to COVID-19, more insurances are now covering telehealth. So that meant that insurances would cover the cost of having an appointment over the phone, whereas before patients had to physically come into the office to have their visit covered. So this could definitely help expand access to care for people who either don't want to go into the clinic or can't make it into the clinic. But the main point still remains, providers need to learn new affirming skills. And so like mentioned earlier, we turned essentially all of these codes from our focus group into our survey questions. We needed to confirm if what we found in our focus groups matched with the broader audience. So we had several other codes that, while they weren't listed on the previous slide, still made it into our survey. And it took several rounds for us to review codes in order to finalize that main topic, because there was such a wide range of things to cover for our needs assessment survey. And then this survey was disseminated to LGBTQ plus individuals, community organizations, and healthcare providers. Overall, we had a total of 56 LGBTQ plus individuals, 14 community organizations, and 36 healthcare providers respond by our cutoff date. And we were really trying to connect with a large audience across California in order to represent the needs of diverse areas. As we all know, California is a large geographic area, and there's a lot of different people depending on what part of the state you're in. So from our respondents, we found that there were differences between what LGBTQ plus individuals were saying they wanted in their care and what they received. So for example, many healthcare providers that responded to our survey didn't think that LGBTQ plus individuals are being impacted by COVID differently than other groups of people. However, as we discussed earlier, marginalized populations are at a higher risk for health complications, and LGBTQ plus individuals are part of vulnerable communities. They're part of every vulnerable or marginalized community in society. So as Katherine mentioned, that compounds the negative effects of COVID-19. Additionally, a majority of our providers responded that they felt they did make an effort to create an affirming environment, but LGBTQ plus individuals were not responding that they felt they were in an affirming environment. So this corroborated what our focus groups were telling us. There is a lack of awareness around LGBTQ plus healthcare, and service providers don't know how to provide that affirming care. So as a group, we really used these results to shape the final deliverables for our educational campaign because we wanted to target and address these gaps in knowledge. So due to the nature of this incredibly comprehensive topic, we didn't want to compromise any knowledge from our research. So we prioritized into 9 topics that you can see listed on the slide. And for the social media strategy of the campaign, we had 3 topics per week, and each topic was designed as a carousel of images that could be posted on various social media platforms. And we felt that this was the best way to include a lot of information while still making the post suitable for social media, because we know that if people are overwhelmed by the amount of writing on a post, they're just going to scroll and keep moving and not take the time to read the information. So we didn't want people to miss out on our information, and we wanted to capture viewers' attention as well. So we had 36 graphics that were created by our designer Moon. And I'll show you an example of how this looks in just a second. So we also created a social media toolkit and a PDF booklet that, again, was beautifully designed by Moon. And the toolkit includes a calendar with images for each social media channel. And the PDF gives an overview of the entire project, including the social media content, additional LGBTQ plus resources, an overview of the project. And this PDF was really important to us because it allowed us to include more information that you can't necessarily fit onto a social media post. But if someone is interested in learning about, they can still access this PDF booklet to gain that knowledge. So we sent these materials to our 90 plus partnering organizations for dissemination to medical care providers, community service providers, and LGBTQ plus individuals. And throughout this process, we kept a list of organizations that could disseminate these materials through their own channel. So we're really grateful for everyone that worked with us, for those who were more involved in the project and helped with focus groups and reviewing our materials, to those that were able to disseminate our final product through their own social media channels. So this is a screenshot of our social media toolkit. It's a zoomed out version, so you can see an overview of the whole project. And our posts are divided over 3 weeks. And this is an example of how 1 week looks. So on the left-hand column is information on how to download and access the images. The middle column shows in what order these images should be posted. And the right-hand column provides a caption depending on which social media platform you use to post. And like I said, we did 3 posts per week. It followed a Monday, Wednesday, Friday schedule with a carousel of the 4 images for each post. For week 1, our content focused on underlying barriers, healthcare inaccessibility, and tracking LGBTQ plus data. And then for week 2, again, we had those 4 images in order to provide greater detail on our topic focus for that week. And then the caption would give a general summary and links to our PDF for more information. And week 2 focused on LGBTQ plus healthcare needs, external impacts, and working with LGBTQ plus individuals. Again, in week 3, it follows the same setup as the other information with info on how to gain access to all the materials, the order they should be posted, and a caption. And our content for week 3 focused on affirming visual practices, affirming language, and affirming processes. So this is how our content looks in the PDF booklet. If you are interested in accessing this content, I see that Katherine just shared the link to our Google Drive, and that will give you access to the social media calendar, all the images you can download and post, and the PDF booklet as well. And the visual aspect of the PDF booklet is the same as a social media post. We really wanted to tie in our work for the whole campaign. So when you link from the social media post to our booklet, you can see that they're all part of the same campaign, and it's just furthering the information given out. And so something we decided on when planning our goals for the visual process is that we wanted the post to be simple but impactful. We know that on social media, the images need to be catchy to keep the viewer's attention, while also relaying important information in a clear and concise way. So I really liked how the PDF booklet, we were able to include all those extra details that you can't get on a social media post. And another benefit to delivering our materials in this way is that it's an easy and quick way to transmit information while remaining socially distanced. It can all be distributed virtually. You can send it to anyone. Anyone has access to the link. So it makes our information more widely available for people to view. I'll hand it back to Katherine for the Q&A.
Thank you, Danielle and Trent. That was awesome. You guys did a great job. And we're happy to answer any questions that y'all might have, or at least do our best to answer any questions that you might have.
Hi, I was just, my name is Primrose Igonor. I am psychology faculty and the Belonging and Equity Coordinator at Marian Technical College. I was just intrigued about the smoking statistic and wanted to know why there's that tendency for LGBTQ plus individuals to smoke more than none.
Yeah, I will answer this from my perspective in terms of doing equity work with LGBTQ folks. And I would say that in general, we have a tendency to engage in behaviors that can be self-harming. And this can start at a young age through adulthood as what I would call maladaptive coping strategies to insidious homophobia, transphobia. And this is basically a way of dealing with not being accepted in society or having internalized self-discrimination as well. So smoking is one of those maladaptive coping strategies, along with other things like high risk sexual behavior, drug and alcohol abuse, self-harm.
Well, that makes a lot of sense. I'm not trying to liken LGBTQ plus to mental health, but as a former clinical psychologist, that's something that we saw a lot of people with mental health disorders, either smoking to relieve any kind of stress, anxiety. So that makes a lot of sense. Thank you so much.
Yeah, you're welcome. And I think it really does tie into the, reason behind this research being so important, this project being so important, which is that, we need to be able to go to the doctor and get affirming healthcare, particularly during a pandemic and public health crisis. And not knowing if that's going to be a safe experience or not is one of those contributors to something that makes us have higher rates of, stress, anxiety, and turn to maladaptive coping behaviors. So thank you for the question.
No problem.
So there's a question in the chat says, did your research consider intersectionality and reveal any disproportionate effect on BIPOC folks? Black, Indigenous, and people of color folks.
Yeah, thank you. Trent or Moon or Danielle, sorry, do either of you want to answer that, or do you want me to?
I mean, in short, yes, because the focus initially was to, we knew that the most vulnerable portions of the LGBTQ plus community would be the most impacted. And in our initial research, we looked into specifically a lot how Black and Brown communities were being affected by COVID-19. And then we also discussed that throughout our focus groups, especially because we had so many community organizations and LGBTQ serving organizations that worked with Black and Brown folks. I don't know, I was gonna say Danielle or Katherine.
What this reminds me of, I believe it was from our focus group interviews when we were talking to some people from Salinas. I remember what came up in our codes was that people working in, I believe it was Salinas farm working communities were being disproportionately impacted by COVID-19 because their families were working, had farm worker positions, and while they were still having to work every day, and they were seeing high rates of people being infected with COVID-19. And then when they were living in those communities, people were talking about how due to their socioeconomic status, they a lot of times had a lot of people living in one house. And so when one person was infected with COVID-19, there was nowhere else to separate or quarantine. And so while that came up in our focus group conversations, it still relates because LGBTQ plus individuals are part of these households and families and communities. So this can really negatively impact people who then may not feel comfortable going to the doctor for fear of discrimination or with a combination of their immigrant status. And these are all real fears that people have, and that was affecting their health and well-being.
Thank you, Danielle and Trent. And then Lisa, I would also, to answer your question, I would also say that when we were looking at the communities in which we were going to conduct the research, considering the size and scope of California, we were very intentional about the communities that we chose to do work in and who was invited to participate in our early focus groups. And so it really shaped the entire lens that we looked through and developed the assessment based off of. And then the assessment did go out across the state. And at that point, you know, we had made sure that we addressed questions and concerns that came up in our focus group interviews through the survey, but we didn't analyze survey results specific to race or ethnicity, mostly because we didn't, we weren't looking for a large enough group of people to participate in that needs assessment that research would have been very meaningful. We wouldn't have had enough folks to do statistical analysis in that way. So I hope that answers your question, but feel free to follow up if that doesn't. I'm trying to understand if is the concern about the link to the document on here, or is this a link to the other links that were posted?
No, I was able to figure it out, so that's
okay. Okay, great.
Lisa had a follow-up question about why was Los Angeles County not included in this research. I wanted to specifically include in methodology. We contacted every major LGBTQ serving center, including multiple in Los Angeles County and also multiple healthcare practitioners, because out of those like 10 counties, Los Angeles was one of them. However, not everyone had the bandwidth to participate, which limited the geographic scope, unfortunately, but they were asked to participate. But like I would have preferred to have more, I think, urban counties, but a lot of LGBT centers at the beginning of the pandemic did not have the bandwidth to participate in a project because they were just trying to survive. Ooh. The question was asked, do y'all have information on LGBT plus Montanans affected by COVID or know of a resource for that?
I am not aware of a resource for this. I'm happy to do a little bit of digging and see if I can send something maybe to Paul, if I can find something. Any other questions that we can answer for folks? Okay, do you want to go to our last slide then? Great. So here is our contact information. If you do have any questions that come up, hopefully you were able to access the toolkit yourself, and please feel free to use and distribute what's in that toolkit, and reach out to us if you do have any questions or follow-up.
Wonderful. Thank you so much, all of you, for that amazing overview of the research and amazing results. We will encourage you also to post that information on our document share if you're able to as well, and that'll remain active throughout the summit. Just want to remind everyone that you will have to log back into each session. We'll be starting at the top of the hour, and please do post to our question board, our Jamboard, and our document share, and you'll be eligible for lots of great prizes, books, and other things throughout the summit. We'll be announcing those door prize winners at the end of each summit day. So if there's nothing else, any final words, Katherine, from you or anyone else?
I just want to say again, thanks so much to the research team and to Moon. It's been, it was such a unique pleasure to do a research project in this way, and to be able to work with Trent and Danielle, who I wouldn't normally have had the opportunity to work with. So it was fabulous. You all did an amazing job, and just really excited to see what all comes next for you. So thank you all so much.
Wonderful. And back at you. Thank you so much for sharing with us. You can see we've got the link posted in the chat for all of our sessions for the rest of the day and the rest of the conference. Again, we'll see you at the top of the hour in about 20 minutes or so. And thank you again all for joining us. We'll see you in just a few minutes for our next session. Until then, bye for now.